So good morning, everyone, and thank you for participating in this talk, which I've titled Death by a Thousand Cuts. And I think as we go along, you'll understand why I'm using that term. And I want to explain how I got to really look at this phenomenon for a long time. Is that, of course, you see here Beyonce, Serena, and this woman here as well is Serena Williams, who is a CDC epidemiologist. And so these are women who are extremely intelligent, right? Successful in their careers. But they also had something in common. And it's not just that they're Black women, but these are also women who had serious complications in their pregnancies. So serious that it could have led to the death of Serena and Beyonce, and they have written and spoken about this, and it did lead to the death of Dr. Irving. So what I'm interested in looking at, and I've looked at for a long time, is the ways in which culture shapes health outcomes. And what I'm going to look at in today's lecture is really using a reproductive justice lens to understand that. And the reason I use death by a thousand cuts is because it's this idea that you're not just being murdered because of one thing, but your death is brought on by multiple layers of experiences. And this is sort of shaping where I'm going with this here. So these are Black women who, again, are financially secure. I'm sure Dr. Irving had great health insurance. She was, again, an epidemiologist with the Centers for Disease Control, had a PhD. Beyonce, Serena are extremely successful. But it's important to note that these women are not unique. In fact, there's been a lot of focus right now on Black women and their mortality during childbirth. What they're finding is that there's a huge disparity in maternal and infant deaths between Black women and other groups. In fact, it's so disparate that you find that a 30-year-old Black woman who is highly educated with PhD is more likely to die, or her child will die during childbirth, than a white, low-income female with the 8th grade education. That's not just simply about race, but that's about multiple factors that are leading to really negative health outcomes. So what I want to look at in today's lecture is the ways in which these multi-level factors affect Black women's health, and I'm going to use a reproductive justice lens to do that. So overviewing today's talk is I'm going to start off by looking at the state of Black women's sexual health in the United States and framing it from a really sort of socio-historical lens. And then I'm going to discuss why the reproductive justice framework is not just only useful, but necessary for looking at Black women's health, because it helps you see the ways in which demographics are one level of understanding the ways in which Black women's sexual health experience different sort of inequities in terms of outcome, access, and care. And to do this, I'm going to use the World Health Organization's 3 dimensions of assessing quality of reproductive health. So I'm going to integrate the reproductive justice framework on top of the dimensions of human condition, service, and approach. So before I start, I always have people that start saying, well, is this just about Black women? No, in fact, what you find is that there are all kinds of health disparities across different identities of women and men in the world. And this lecture could easily be done using similar frameworks and approaches when we look at Indigenous, First Nations, Native American women who experience extremely high rates of negative health outcomes, and particularly reproductive justice. For Hispanic women, for Asian women, etc., for white women. What it really ties down to is using an intersectional lens, and some of you might have already heard about this. It's a popular term that's being thrown around, but it needs some more investigation. But very briefly, what I'm talking about intersectional here is that there's multiple layers in terms of who you are. So I'm using the term that I'm going to focus on Black women, but there's very different experiences being African American versus being an African American with a Caribbean background or being from Africa. And also it depends on the country and the reason for migration or forced migration or being kidnapped, etc. So an example I like to think about is we use this term Hispanic broadly, but there's a very different experience if you're Cuban coming here versus if you're Mexican coming here versus if you're a Venezuelan coming here now. Even within Venezuelan populations, a difference with if you came with money or had families, money established in Miami before versus if you're escaping now with the clothes on your back. So there's multiple ways in which we experience outcomes. But I'm going to focus on Black women's. And when I'm looking at Black women's, why I've chosen to do this is one, because I am a Black woman, but two, it's really interesting in terms of looking at the research, because most of the research historically is focused on either Black or white populations. Of course, we're changing now, but historically that's where the bulk of the research, particularly around minority populations, are focused. But also for Black women, it's so unique the ways in which history and socioeconomic forces shape their sexual health outcomes, irregardless of their social class, social economic status, their education, and other identity factors that people would assume would buffer them against negative health outcomes. So it's really common to look at some of the broader health outcomes. And when we look at Black women's, we do know that they experience some of the most negative. So again, they're more likely to die in pregnancy or during childbirth when compared to white women. They're 3 times more likely to experience an unintended pregnancy, which is corresponding to the fact that they're 3 times more likely to seek or obtain abortion services as compared to white women. When you're looking at STIs, or sexually transmitted infections, Black women are also 5 times more likely to contract chlamydia, 10 times more likely to contract gonorrhea and syphilis, and they account for a significant number of diagnosed HIV cases. However, they're less likely to be linked to care and access care and treatments that are critical for their long-term mental health and physical health as well. Looking at another reproductive justice issue is violence against women, and we find that Black women experience higher rates of intimate partner violence than white females, and almost double than other races. And even when we look at developmentally, adolescent Black girls are more likely to experience dating abuse than Hispanic or white again. So when you're thinking about this, you're going to start wondering, well, what does this mean? Is it just simply because you're a Black woman that this is occurring? No, there's a number of factors that tie into this. And this is where the reproductive justice lens frames. It's simple for us to say, well, Black women have these rates, and etc. But a lot of this is tied to, well, how do we know these rates? How are they reported? How are they collected? Who's willing to report it? How are access to services giving these numbers? All of these things tie into looking at this, and this is what we're going to talk about. So when we're looking at reproductive health, one of the first things that people think about is reproductive rights. And most of you have probably heard about this concept of reproductive rights. And so reproductive rights, you've heard this, people waving, my body, my choice. I have the choice to be sexy and engage in pornography. I should have access to things. All of these are really tied to rights and what people have in terms of what is given to them in terms of their liberty, autonomy, and equality. What access do they have to accessing these rights? But when we think about rights, it assumes that people all are entitled to these, and people can easily exercise these rights, regardless of their status. And we do know that it sort of overlooks, again, this idea of intersectionality, the ways in which inequities are tied to our intersecting identities around race, gender, and other socio-historical experiences. So one of the ways I think about this is that they could give us sex education. We can tell someone, for example, that you need to use a condom to stop the spread of HIV. But if you don't have the money to pay for a condom, or if your local pharmacist refuses to carry condoms and there's no other place you can buy them, or if your religion tells you you're not allowed to use them. All of these types of things then shape your ability to actually use your rights. And so these are the things that we have to think about. Now, those are very simplistic, but I'm going to look at them in terms of a broader framework of understanding that it's not just simply about rights, it's about justice. It's a broader understanding of the ways in which economic, social, political powers all shape our ability to access these resources and services. And this is critical for being able to make healthy decisions about our bodies, our sexuality, and reproductive health. So this is why I use the reproductive justice lens. And that's because reproductive justice ties in more than just your individual level health. It ties in your physical, mental, spiritual well-being, along with your political, which would tie to your empowerment, economic, and social well-being. And it's of girls and women, but it also has implications for men, because research has also shown that when women are healthy, their families and their friends are more likely to be healthy, as are their communities. And so reproductive justice doesn't just look at the individual level, it also looks at the way this is connected to broader frameworks in terms of where women interact and who they interact with. So the way to think about it is that it's not so much that it's oppositional to reproductive rights, but it sort of fuses social justice and human rights and reproductive rights together in terms of understanding reproductive justice. So it's, of course, then no surprise that the concept of reproductive justice actually emerged from really community level activism of women of color. And this is sort of in the sense that what's really happening in the world. This is the movement that sort of forced people to start thinking beyond just what are the statistics. It's more like, well, why are the statistics this way? What factors are influencing decision making or people's ability to make decisions? So you'll find that there's this, this move towards reproductive justice to sort of really understand the ways in which outcomes are affected in a broader socio-historic and social justice lens. So this concept of sister song is actually from the Women of Color Reproductive Justice Collective, and they came up with the term reproductive justice. And Sister Song is made up of the Hispanic Women's Reproductive Health Collective, the Asian Women's Network, and the Black Women's Health Network. And this is sort of, they branched off from Planned Parenthood to sort of look more broadly and address women's health issues by using a lens that provides a more comprehensive look at those populations that are continuously marginalized and experience greater levels of systemic and institutionalized racism. So again, this goes back to the ideas in which social systems are critical for understanding health outcomes. So social systems, and we've kind of been talking about this earlier, are the little networks in which we live. So who we know, where we live, who we interact with, all of these things determine our access to reproductive health. And for Black women across socioeconomic status, SES, education, and even things like access to resources in terms of health insurance, there's a continuous sort of disenfranchisement about their reproductive health that has been pointed to and been identified as institutionalization of systemic discrimination. And again, the examples of Beyonce, Serena, and Dr. Irving highlight that, and we're going to talk about it. So it creates this sort of chronic stress that happens over time. And there's this never, this period of rest, and this type of stress then informs your health outcome and your ability to make health outcomes. And so again, this is not something in which education and class and economic class can provide a protective barrier. And so this is what's important to think about when we're looking at reproductive justice in terms of what we're looking at here in this presentation. So what we're thinking here is that it's these systems are really sort of institutionalized over a long period of time, and they really directly affect women's ability to make broad reproductive health. And again, I'm focusing specifically on Black women. And sort of to give examples of this, I'm going to look at these, the influence in terms of outcomes and present it from looking at it demographic levels in terms of the place and space and location that Black women occupy for understanding the ways in which institutional and systemic racism influences reproductive health experiences, both longitudinally and in terms of the current climate that's occurring right now. So again, I said earlier, I'm going to be using the World Health Organization's 3 frameworks of human condition, approach, and service. The World Health uses this to gauge and assess the degree to which people are healthy. And so they don't just simply look again at the statistics, because that doesn't give you a big picture. They look at how these 3 domains intersect to lead to barriers or improve health outcomes globally. And so it's really helpful to use this sort of framework to look at things from a reproductive justice lens, as it organizes our understandings of the ways in which different levels of demographic and contextual factors shape Black women's reproductive health in the United States. And so I'm going to first start off by looking at the concept of human condition. So what are we talking about when we talk about human condition? Well, human condition is about where you are. So this is your place and location, your demographic factors. So it's your characteristics, the events and situations in which you live in the immediate place. It ties into the idea of what's going on in the context of which you live, in more the immediate context. So the example I gave earlier, for example, of if there's conflict going on in your home country, and you escape, let's just say you escape and immigrate to the United States, you're going to have very unique health experiences that aren't just tied to the physical outcomes of the escape, but also the mental, your access to resources, your ability to negotiate things. And so you think about it in terms of the suffering you experience, which could be tied to, really sort of concrete things like war, or even more commonly poverty, oppression, or disappointment. So it's the context and situations in which individuals face daily, they influence how people are treated, how they feel they are treated, and their ability to access treatment and see the world around them. And that sort of ties into how they are able to feel that they're secure economically, or in terms of their health and their overall quality of life. So it's really useful to use a socio-historical lens to sort of give meaning to what we're talking about. And I start off by looking at this map of the United States. And so when you're looking at the United States, this is a nice big picture that we see all the countries here, and not countries, sorry, all the states that exist. And other countries look at the United States and they see this, but we all know that the United States is really distinct. So each region has its own culture, its own history, its own values, its own sort of political and social identities. And so when you look at the maps like this, it's nice to see all these states framed in this way, but depending on what you're looking for and who you are, you might look at the United States very differently. And so I know for myself as a Black woman, this is how I looked at the United States. And this made a huge difference in terms of how I even made decisions about where I want to go to graduate school and where I want to end up living. So if you're looking at this map here, what it's showing you is the United States, and you can still see the outlines of each state, but it's more important to recognize that this is showing the racial and ethnic concentrations of populations in the United States. And if you think about it historically, or even in terms of cultural and political context, you can kind of guess what each of the colors mean. So of no surprise, if you look at the greens, the darker greens are Hispanic populations, or 2 or more minority groups, which tend to be, when you're thinking about the 2 or more minority groups, it's Hispanic white together. And of course, it's not surprising that these are located in states that are predominantly closer to Latin American countries, the Caribbean, Central and South America. And that's tied to migration. This is a 2010 census. If you picked up the census from the 80s, you'd find it's very similar. Similarly, you can see Asians, you don't see them as much, but they're concentrated in certain regions, specifically by what jobs and economic ties are there. Then Blacks are in this region here. They're concentrated in a very specific region. And so when you think about this, as a person of color, when you're moving somewhere, you often think about, where am I moving? Who's going to be around me that it looks like me or thinks like me, or would even think in the same ways in terms of the cultural issues you have to consider, including health. So I kind of said earlier that if you looked at this map 20 years ago, it'd be very simple and similar. And University of Berkeley actually did a great job with showing a map, that this one specifically on Black populations. And if you look in the lower left corner, you could see it showing how Black populations have shifted over various decades. And if you think about what's going on here, you can kind of tell what's shaping where Blacks live. So for example, when you're looking at the map right now, early on, there are no Blacks really over in this California region. Then all of a sudden in the 40s and 50s, there's two huge concentrations in two huge city areas. And that's because during the war and jobs and industrialization, the same thing over here, you suddenly see Black populations concentrating in the north, shifting from the south because of what was happening politically and economically in the United States. But it's always consistent that Blacks remain in large numbers in this area. And this area has two names. One is the Bible Belt, which a lot of people are aware of, which it's about very traditional religious views and strong ties to Christian-based religions. But the other one, which demographers are more familiar with, is the Black Belt. So this region is called the Black Belt because this is where large populations of Blacks were forced into slavery. This is where the cotton plantations were. This was where the jobs that Blacks were, and I use the word jobs very loosely, but these were where Blacks were forced to work. And as a result, they, because slavery went on for hundreds of years, the populations sort of stayed there and remained there because this was where their communities were built. Now again, populations shifted when jobs moved, but if you look at more recently, Blacks are again moving back to the south. There's a whole body of research. So you can see the ways in which socio-historical cultures and factors shape where people live. And this then ties into where they have access to healthcare, etc. So this is a 2011 census. And again, you could see more clearly without the movements that Blacks still live in this Black Belt area. And these darker areas are where there's urban concentrations, etc. But their numbers still stay consistently with where Blacks operated during slavery. And that's also because living in other parts of the United States, as I showed earlier, would lead to forms of isolation. Again, this affects every other group, other groups as well. So when you're thinking about this, it's important to think about the ways in which where you live, your demographics, will have implications in terms of your racial identity, experiences with racism, and then your overall health. And again, by looking at demographic factors such as maps here, you could look here and see that this is a map that has nothing to do with race, or ethnicity, but it's tied to states and county level understandings of health and well-being. And overall, this is including, what I should just say, well-being, education, income, mortality, and just general health. And if you look at this, think back to that map I showed with race, you'll see that certain areas where there's large numbers of minority populations are more likely to be doing worse, and particularly in areas, again, the Black Belt is consistently doing worse. And this is overall. When you look at it in terms of healthcare specifically, and this means accessing healthcare, behaviors, clinical care, the policy, again, the Black Belt, because the darker ones are doing worse. Now, I also want to just point out a couple of things. You'll see that these areas are also not doing Arizona, New Mexico, Texas. That's, again, where you're finding large concentrations of Mexican Americans. But I also, as we're going through today's presentation, keep looking here, North Dakota, South Dakota, all of these places here, you'll see that they also experience unique health inequities. This, of course, are Nebraska, Kansas, Oklahoma, and Texas. So you'll see that these are certain populations are living in these areas, and you could see which ones continuously have poor health. Now, Vermont, New Hampshire, and Maine are very wealthy states, and they're predominantly white states. And you're going to see very different outcomes there. And also the District of Columbia. There's a large Black population, but also because DC is the nation's capital, you have a large wealthy population of whites, Hispanics, etc. So DC is kind of like an outlier in terms of how well it's doing because of the populations that's there. So again, I want you to think about it here. The worst states, as I pointed out, are these states. Again, the Black Belt states will consistently remain in here, and then you have North Dakota, South Dakota, etc. Well, are doing well here, but as well Minnesota and Iowa. And they tie this again to the ways in which public policies in terms of healthcare shape outcomes. And again, Vermont, Massachusetts, and Maine are doing well. And you're going to see this consistently coming up again. Now, when we're looking specifically at reproductive rights, you can see this here. And again, this is because of rule. So this is tying to another sort of intersecting identity. But again, the black belt is consistently doing F's to C to D grades in terms of its overall well-being. California seems to be doing well, as long with Oregon, etc. And that has a lot to do with the public policy and roles around how people can access and how it's supported. And we're going to talk about that a little bit more when we talk about approach there. But again, this ties to the ways in which where you live or your human condition shapes your outcomes. So social disadvantage, if you live in areas where you don't have access to services, or you live in high poverty areas, or if you live in rural areas, etc., this really corrodes health. And this is where the concept of weathering came from. And Geronimus, who is a professor at Harvard University, came up with this concept of weathering. And it's been around for several years, but it's become more popular because of the increased attention to Black women's mortality during childbirth, and as well as the increased rates of Black women's babies' death, this whole disparity. So the concept of weathering really comes from the idea that it's a biological response, that these women's bodies are essentially breaking down or becoming more stressed to protect itself as a way to protect itself against years of social disadvantage. So those of you in the biology majors have probably heard of allostatic load, and that's a form of physical stress response. And so you have this, and it causes the hormones to sort of start rushing through the body. And as a result, it causes the heart to run faster, and you enter this sort of fight or flight mode response. And so what they're finding is that Black women, because of their long experiences with health, in terms of their context in which they live, their experience with systemic racism, it's actually, their bodies are actually sort of causing greater stress to themselves. And this is contributing to not just only maternal deaths during childbirth and infant mortality, but it's also causing Black women to experience really fatal chronic conditions at an earlier age. So you can die from hypertension and type 2 diabetes, and you find that happening earlier. Then it also leads to greater negative mental health outcomes such as depression and sleep deprivation. So relatedly, when people are coping, they're choosing a lot of negative coping behaviors because, again, we talked about accessing healthcare. There's other ways to cope. So overeating, drinking, smoking, using substances. And so the research that's being done right now at the Harvard Chan School of Public Health is really finding that this is really critical to think about, is that you have to think about the ways in which where you live has high levels of stress, and not even where you live, but who you are in terms of its impact on how you identify is really going to cause greater health and stress conditions. So tied to this then is the service, and service is what we tend to focus a little more on, but service is really focused on the provision of or access to services that sort of are related to reproductive health, and that's what we're looking at here. Now again, the World Health Organization looks at all aspects of health, but we're going to look at it in terms of reproductive health. And what you find is it's about not just that do the services exist, but are the services being given in a way that is culturally competent or given in a way that's even just basically equitable? And do they address all aspects of the person's well-being? So you have to start thinking about broader definitions of empowerment in terms of service. So it's useful to consider this domain from a discrimination lens. So one of the ways we can think about service is even being able to go and get services. So the story I always talk about is that I am a Canadian. So I grew up with universal healthcare. So you pay a lot of taxes, but school tuition is pretty standardized across the country. Access to school is standardized. And you just go to the doctor. So the idea of not being able to go to the doctor is really was confusing to me. But it became clear to me when I was a grad student, I moved to the United States, and I had to use my health insurance, which is part of being a grad student. And at the time I was making $500 a month, and I was in school in Buffalo, fortunately, which is only 2 hours from Toronto, where I'm from. And I had to do a $20 copay. Well, if you're making $500 a month, a $20 copay is quite a bit. That's my electricity. that's my gas, etc. So what I would do is I'd make the decision, no matter how sick I was, to just sort of ride it through and then get on the bus, or if I was really sick, or if I could, get in my car and drive back to Canada to get my health insurance. If you don't live in Buffalo and able to cross the border, you're not a Canadian, you don't have that choice, which is most people. So when you look at the issue of being uninsured, even though we can have doctors, in my case, I had doctors, being able to pay for it means that you don't have access to the right of going to a doctor. There is something else blocking it. So this is why the concept of the reproductive justice needs to be looked at quite differently in terms of uninsured Americans. So again, thinking about the green belt here, this is really critical, that you find these states have high levels without insurance. So the darker the color, the more like it is. And again, you'll see these colors here that are happening. But again, the Bible Belt consistently has high rates of Americans who are uninsured. So even if there is a doctor in town, if you don't have the insurance or the money to go, it doesn't matter what rights you have. Similarly, mental health, and we talked about this, that if we're looking at human condition, the source of stress has such a huge impact on Black women's bodies, particularly around mortality during childbirth, which was the outcome of one of the studies with the weathering. So you're going through all this stress, but you don't have access to mental health care services, then that's also problematic. And again, we see that the darker the color, the worst 10 are again all in the Black belt. So for Black women, this really has an implication, because this tells you a lot more about accessing services to deal with this stress is going to be really problematic. Then, even if you access it, what about the person that's providing the service? So what you have to think about is if people are getting the services they like, if they're being treated differently, and this is again where the concepts of institutional racism and other forms of discrimination are really important to think about. And if you look at this study here across the board, minority populations, including Latino and Asian American, they are less satisfied with the care they receive. And this is a huge difference between whites. Asians, Latinos, and African Americans are basically within 4 points of each other. But white, the next closest, would be 10 points away from Asian American. So there's huge perceptions of difference. And what is the importance of considering these perceptions? Well, if you have these perceptions of difference, you are also going to be someone who's not going to regularly go to a doctor. This level of mistrust, and often it's because the providers, you're less likely to go and get the services, and you feel that you're not going to get what you need. And as a result, there's also this issue, it might not be blatant racism, but also just a lack of cultural competency from the provider. How do they ask questions? How do they look at the person? What language is used? All of these things matter. Also, where the clinic is located. And we know this is tied to several other factors, because as a result, we know that African American women are least likely to spend a lot of time with their doctors. They have the least patient-physician interaction. They're the least encouraged to engage in medical decision-making with their physicians. And as a result, this then decreases their overall care satisfaction with their healthcare services. And then this ties into the fact also that this might be informed by the fact that Black women are less likely to have a regular long-term healthcare provider. And if you think about that, means every time you go to the doctor, you're going to be seeing a different doctor. And so there's not this narrative over time that sort of keeps track of you, and you might be going to different clinics. And these people have to learn everything over again. So having doctors or healthcare people overall, if they don't get to see you regularly, it's going to make them harder to address issues of mistrust, to address issues of patient-physician interaction. But also living in areas where there's a shortage of specialized healthcare providers. All of these decrease the likelihood that Black women maintain long-term health preventative services and healthcare practices. So you could see the ways in which you're looking at your services really impacts your health outcomes, and particularly reproductive health. I'm going to focus now a little bit on domestic violence, because gender-based violence, GBV, is a form of reproductive health. And again, as I'm showing all the time, this is really sort of a demographic lens for looking at reproductive justice. You could see that the rates where there's highest rates of homicide are across the board in areas where there are lots of marginalized communities that are taking place. But one of the things that sort of contributes to this, research has shown, is about these populations, the marginalized populations' willingness to report and use services and access healthcare. So your health is not just tied to your doctor, it's also tied to your clinicians that are providing other services, or the justice system and the education system. So if you think about in terms of domestic violence, you're looking at this map here, you see overwhelmingly minorities are more likely to not trust the police, and they're also the least likely to always trust the police. And so if you're a victim of domestic violence or any form of abuse, you're less likely to go to the police, which then will increase the likelihood that it's going to become more and more severe, and that can contribute to domestic violence homicides. So trust in the police does have an impact as a service on your overall reproductive health. And we find this in terms of the research looking at battery, that Black women are the less likely to use social or health services to address their victimization. And part of this is because they report that there's a lot of terminology and language used towards Black women that's sort of victim blaming. And it creates a sort of secondary victimization, which leads to more stress and depression and mistrust. And in fact, there even says it shows it increases their rates of PTSD. So for Black women, they're constantly evaluating, should I report, because of the issues of trust? And it's not just simply trust with the judicial system or health services, but also within their family and communities. And this goes back to the reproductive justice framework, in that your decisions and your ability to make health are tied to larger systems in terms of your family, your partner, your community. So if your family and community already has a great distrust in the police, if you go to report to them, you're going to face some sort of negative backlash, because now you've reported to the very people who are problematic, even though they're the ones who might be able to help you deal with what's happening in your this aspect of your reproductive health. So this is where you can find that, again, the intersection of the human condition also affects your ability to engage in approach when you look at the World Health Organization lens. So the reproductive justice lens requires you to look at how all of these intersect, that making decisions to leave or seek services or prosecute someone is not that simple. There's multiple things that need to be considered. And these multiple things will impact your reproductive health in multiple ways. So the last one to consider is service. Is approach. We did service. And so approach is the one that we kind of we've been giving a lot of attention to right now in terms of politics. And we're talking about approach. What we're thinking about here is not just how you, people assume we're talking about how you go forward with services. It's actually more about how directions and decisions are made around reproductive health. So it's focusing more on protocols, legislation, and government planning that sets the stage for reproductive health and how it cascades down to the different systems in which Black women work here. So it's, when you think about it, governments make decisions about funding and what's going to get funded and how it's going to be funded in terms of what services will be there, what education will be provided. And so if you think about in terms of family planning, which is a big topic right now, access to abortion or even getting contraception is really tied not just simply to what you want or what your healthcare provider wants or what your family or the services around you, but policymakers. So what you want to do might not be what you're able to do. So having the right to contraception might be sort of impeded by different types of approach, and I'm going to talk about it. So it's really about the culture that's shaping these sort of legislative systems, particularly in religion and political frameworks that are shaping it. And what I want to show here, for example, is that this is a picture from the left of Dr. Nadine Burke-Harris, who's a Surgeon General for the state of California. Celeste Phillips, she was the health representative for the state of Florida. She's just recently resigned. And then this is Dr. Jerome Adams, who's a Surgeon General of the United States. So they sort of help create the narrative of what the priorities are for each of their states and the larger United States. So often people don't even know who these people are. these are the people that will sort of shape the narrative that provides what you and Black women can have access to or are able to do in terms of their reproductive health. Now, a lot of times we look at the politicians, and this here is, of course, current Governor Rick DeSantis, President Donald Trump, and Florida Senator Rick Scott. I'm using their example because I'm in Florida, that yes, their politics and their policies shape decisions, but each of them operate at very different levels. So this is why also why politics are important to think about when you're thinking about reproductive justice. So the approach is all of these policies and legislations that are often happening beyond the individual Black woman or any woman that really shape her reproductive justice health outcomes. So one level way to look at this too is that this is not simply a Republican Democratic framework. This is over time, because it's important to note that whatever happens in terms of policy was really determined by what was discussed and decided probably 2 and 3 years ago. And you could see that it shifts in terms of priority depending on what's happening in the country at that time. So this is the Guttmacher Institute was looking specifically here at state level efforts to improve reproductive health access. And what you can see is that if you look at something like sex education from 2001 to 2004, their efforts at the state were really low. But then if you look at it from 13 to 16, there's been a real push for state level reproductive health access. Similarly, if you look at contraceptive coverage, it was somewhat high here, then it decreased in 2005 to 2008, really decreased in 2009 to 2012, and then there was a significant increase. And then what you're looking at, expedited partner treatment for STI, so that means having your partners being called and former partners being contacted and getting treatment. It was really low. If you look at it here, it increased significantly, and then here it suddenly blew up and it's decreased a little bit. So if you look at these, you could see that it really changes in terms of what's going on in each state. And also it's important to think about what it means too. It's not just to look at it this way, what is comprehensive sexuality education? So that's not just sex education, but there's a difference between, for example, abstinence-only education and broader education that does include abstinence-only. So this is what you have to think about in terms of considering access to services, treatment, the quality, the cost, and what's happening is what we're thinking about in terms of the state level. Here's also abortion access state policies, and you can look again, if we look at a 10-year difference between 2006 to 2016, you could see that there's been huge shifts. And so these are state policies, but these are informed by other broader influences, which includes a religion, politics, and individuals who are in decision-making positions. So even if you have the right to abortion, your ability to access it differs greatly between 2006 to 2016. And this is really important to think about when you're thinking about all those issues that we talked about that are unique to Black women's sexual health outcomes. And then state policies on contraceptive coverage. You can see this is the Henry J. Kaiser Foundation. And so what you're finding is the states that are gray right now, those don't necessarily have specific policies or they're not reported, but you can see that each state has very different coverage requirements. And so this is then we could say that you can get contraception in the United States, but where you live is really going to shape whether you can actually get that contraception coverage. So again, going back to what we talked about at the beginning, it's not enough to talk about reproductive rights, it's important to use a reproductive justice lens. Now, this is where I really think it's important to think about things, because even within your state, there are also other underlying factors that shape your ability to negotiate your sexual health or even take control over it. So if you look at it here, you could see who gets decisions about even providing birth control distribution. So if you look at the state of Florida, individual providers can choose not to give you birth control. So your doctor can refuse not to give you birth control. And if you're looking at it in terms of healthcare institutions and individuals, so that means hospitals can also refuse to not give you birth control in Mississippi and Tennessee. In South Carolina, emergency rooms can refuse to give it to you, and individuals can refuse to give it to you, even if it's caused by rape in South Carolina. So even though there is access to birth control, it could be determined by who's living there that you can access it. So if you're in a small town and there's only one pharmacist, then you might not be able to access your birth control. Or you're gonna have to pay for it to be delivered, which then can put you at risk because, say, your partner doesn't know you're using birth control, or your parent doesn't know you're using birth control. So all of these things have to be considered when we go back to the earlier slides about sexual health outcomes. If this is just about birth control, we see the same things even in terms of getting tested for different sexual health diseases and STIs, or even getting access to report and understand. These things can all be shaped by where you live. Then this is, I love looking at the pharmacist one, because you think about it, we don't think about the pharmacist. I don't even know who my pharmacist is, but when I was living in Georgia, he could have stopped it, or she could have stopped me from getting birth control. Now, I was a student living on campus when I went to school in Georgia. So fortunately, most universities, or I should say I was at a large state university, so they were providing it. But if I was at a more Christian school, or if I lived in a rural area, the pharmacist could have chose not to give me birth control. So this is really interesting that if you didn't realize, not all states require pharmacists to fill birth control. So if you don't want to in your Texas or Alabama, they can refer you to somewhere else. But this also shows you the ways in which policies can shape your sexual health. And this isn't new. If you look over time, you guys, a lot of you who might be a little young for this, but Norplant, which is a birth control contraceptive, it's actually surgically inserted into you, and it releases a hormone over a period of time. It could be anywhere from 1 year to the point that I believe they got up to 5 years. And what was interesting was that in the late 90s, there were actually lawmakers that were introducing bills to make Norplant mandatory for women on public assistance, a large number who were African American, and those were in states, not across the United States, but in states where there were large numbers of Black women on public assistance. So basically, the government was going to make decisions about women's reproductive health. In 2003, they also wanted to put policies in place to test welfare recipients. And if a woman was found to have drugs in her system, she was going to be charged with child neglect and abuse. So this was going to also affect her outcomes. But what's interesting, if you look at something like the opioid crisis today, we're not having these same discussions. So the idea of women who might be tested for heroin use or opioid use, we are not discussing of testing it and tying it to persecution of mothers for child neglect and abuse. And part of that is because who is the population that's that are abusing the most that we see in terms of heroin and opioid use? Well, these are typically middle-class populations because a lot of them got it from their doctors, etc. So you could see the ways in which different sort of frameworks, human condition approach, and services come together to shape how policies are even thought about in terms of what's being pushed and what's not being pushed around women's reproductive health. In 2017, in fact, the federal administration put a policy in place that allowed your employer to say that, well, we're not going to pay for contraception, or we're not going to pay for certain services. So they could have said, we're no longer paying for your Pap test or going to gynecologists, or we're not paying for birth control. So this was being put forth, but it's currently being blocked, and states can choose to do what they want. But this is now telling you that your employer then is getting to make decisions too around your reproductive health in a way that you might not even think about. That's important to think about when you're looking at the big picture of the ways in which Black women's reproductive health is informed by multiple levels. So if you look at the leading organizations around healthcare, which includes the American Medical Association, the American College of Obstetricians and Gynecologists, and the American Public Health Association, all support the right to universal contraception access. And that's because research has shown when women have control over their contraception, whether to use it or not use it, it decreases negative outcomes across the board. In particular, when they look at for Black women, it decreases all those negative outcomes we saw earlier, including unwanted high-risk pregnancies, maternal morbidity, unsafe abortions, and it even allows women more control over their lives in terms of experiencing violence. But if they don't have control over their reproductive health to use these things, it keeps this sort of system of oppression and disenfranchisement in place. So again, when you're looking at these three, they come together. You cannot look at human condition alone, which is what we often do, or service alone, our approach. They come together to affect Black women's health in very specific ways. And again, it can affect women across the board and men across the board. But if you're thinking about it in terms of how I showed you socio-historically, you could see the ways in which it's affected Black women's health, particularly around the phenomena I started off introducing us with about infant mortality and risk in a really sort of unique way. And so what you're helping to see through the reproductive justice framework is that there are different intersecting points that you have to consider if you want to understand Black women's sexual health experiences. And that's irregardless of their level of education, their economic status, or their level of social class as well. So this is what is important to think about, that is an intersecting lens that needs to be used. So the big take-home points is, again, that Black women's sexual health and knowledge, you can't just look at it in terms of, here's their statistics, here's the outcome. What are the broader socio-historical experiences that sort of shape these outcomes and these statistics? The second thing to think about is using this sort of reproductive justice lens to identify where these sort of inequities in health in terms of access, approach, and human condition are really occurring. And that's where you can start sort of identifying why these sexual health experiences are occurring the way that they are. And then finally, if you want to make change, by identifying those interventions, then you can realize it's occurring at multiple levels. It's not enough to just look at one level to think about it in terms of addressing it. So you can't just change the human condition if you don't change the service, and you can't just change the approach if you don't address the human condition. And so that's what's really critical to think about. So I want to end again with this idea of Beyonce, Serena, and Dr. Irving in terms of thinking about the ways in which their shared identities, Black women, sort of transcends issues of socioeconomic class and education. But who they are as Black women living in the United States really shapes their reproductive health outcomes in a unique way. And it's important to think about that in terms of Black women and other women's health inequities, and think about ways in which we can address it so that these type of outcomes don't continue to be the norm and business as usual.
Thanks for joining us at this intersection, where we bring together the real world and the world of research. If you'd like more information about this topic, including additional readings or related videos, please just visit my website, dionstevens.com.